السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بالجميع. إدارة الشؤون الأكاديمية وتدريب صحة الطائف ترحب بالجميع اليوم بدورتنا دور الصيادلة في تحسين وصف مضادات الميكروبات واستخدامها. طبعا دورتنا اليوم بالتعاون مع مستشفى الأطفال ممثلة برعاية صيدلانية وإدارة التدريب في مستشفى الأطفال. طبعا اليوم الدورة بقيادة الدكتور فارس رجب النفاعي، هو مشرف وحدة صيدلية سريرية بمستشفى الأطفال بالطائف، صيدلي سريري مختص بأمراض المعدية لدى الأطفال بمستشفى الأطفال، مسؤول برنامج استخدام الأمثل للمضادات الحيوية بمستشفى الأطفال، حاصل على درجة البكالوريوس في الصيدلة من جامعة أم القرى، حاصل على شهادة دكتور صيدلي من جامعة رياض العلم، حاصل على درجة الماجستير في صيدلة سريرية من جامعة رياض العلم. تفضل يا دكتور، المايك عندك.
السلام عليكم.
ورحمة الله. تفضل.
بسم الله الرحمن الرحيم. في البداية أشكر الشؤون الأكاديمية التدريب صحة الطائف وإدارة مستشفى الأطفال ممثلا بإدارة الرعاية الصيدلانية وإدارة التدريب على إتاحة هذه الفرصة، وأتمنى للحضور وقت ممتع ومفيد إن شاء الله. بسم الله نبدأ. طيب. Today we will talk inshallah about the pharmacist rules in improving antimicrobial prescribing and use. And first of all, I have nothing to disclose. Our outlines, we will look at the importance of antimicrobial stewardship program, why we should implement antimicrobial stewardship program in every healthcare institution, and also what's the importance of being a member as a pharmacist of the antimicrobial stewardship program, and what's the role of antibiotic stewardship pharmacist. And also we'll talk about the 5 strategies that CDC have suggested for hospital pharmacists in being an active member of increasing the awareness of antibiotic use. And also whether you are working in a hospital inpatient pharmacy or an emergency pharmacy, or even in the outpatient or community pharmacy, what's the rule that you can implement in enhancing antibiotic use in these different settings. So antimicrobial stewardship has been defined by IDSA and SHEA and PIDS as coordinated intervention that is designed to improve and measure the appropriate use of antibiotics by promoting the selection of the optimal antibiotic regimens, including dosing, duration of therapy, and route of administration. Why it is important? Data have suggested that 30% of antibiotics are prescribed in a correct way or unnecessarily. So this is a huge percent where we can, as pharmacists, do a benefit in improving and decreasing this percentage. And also 20% of hospitalized patients had at least one serious adverse effect that is related to antimicrobial use. Also in 2050, the leading cause of death will be antimicrobial resistant organism. What are the risks of misusing antimicrobial and the negative effect on the patient community and healthcare system. First of all, increase the side effect, as 20% of hospitalization has a serious adverse effect related to antimicrobial. Also, misuse can lead to increased resistance and increase the incidence of C. diff infections. So the optimal rule of antibiotic stewardship program is to optimize, not to decrease, is to optimize clinical outcomes while minimizing unintended consequences of antimicrobial use. So what pharmacists can do as antibiotic stewardship members? First of all, the rule is to optimize patient outcomes and preventing resistance and minimizing adverse effect of antimicrobial use. How can we achieve this goal? By reviewing every antimicrobial prescription. We need to review the diagnosis, the indication, the antimicrobial, also as well as the dose and duration of this antimicrobial. What's the interventions that can we do? There is plenty of intervention. The most important ones are as optimization of the therapy, use the shortest duration, effective duration, and de-escalate after culture result, or even stop if not needed. There is many strategies that have been suggested by the CDC to be an effective pharmacist antibiotic stewardship program member. One of them is pre-authorization. What does that mean? That means you have to restrict some antimicrobials to be approved before using it in the hospital. So restricted prescribing of targeted antimicrobial. This can be restricted to indication of diagnosis or unit restriction. For example, this only can be prescribed in the ICU, and also infectious disease and antibiotic stewardship program only privileged to prescribe targeted antimicrobial. And there is another strategy that if a physician needs that restricted antibiotic, we can give him 48 hours pending approval to be used in certain situations. Another strategy is prospective audit and intervention feedback. So this is basically you need to review patient medical records who are on antimicrobial. So every antimicrobial, in the beginning, you need to start targeting specific antimicrobials or specific infection, or targeting specific wards in the hospital. And then you have to review the indication of every antimicrobial. You need to do a review of culture result and dose optimization or adjustment, and review the route of administration and the duration of the antibiotics. So what are the interventions that can be done while implementing this strategy? First of all, you can de-escalate as soon as the culture have been revealed, or even escalate, discontinue the medication if there is no growth or the patient is clinically stable. Optimization of the therapy, and you can achieve conversion of IV to BO administration, therapeutic drug monitoring, and you can check for drug-drug interaction and check for unnecessary duplicate coverage. So in this study, pharmacist role in antimicrobial stewardship and relationship with antibiotic consumption in hospital. So this basically, the aim of this study was to explore the impact of pharmacist-led antimicrobial stewardship program on the use of antimicrobial. Now, this was a retrospective observational multi-center study, and found that when a pharmacist is the advisor of antibiotic, the antimicrobial use have been declined. So this is another study published also in 2019 by Macmillan and colleagues, evaluation of a pharmacist-led antimicrobial stewardship service in a pediatric emergency department. So the aim of this study was to evaluate the impact of pharmacist-led microbiologic review and follow-up program for patients who have been visiting the pediatric emergency department and discharged with at least one positive microbiological test, and this included a urine culture, skin or wound swab, throat swab, stool culture, and the primary outcome was return visit to the emergency department within 96 hours. So the intervention was that a clinical pharmacist review the microbiological test and initiate, modify, or discontinue drug therapy as required. And this was a retrospective short review pre and post implementation of this strategy in pediatric emergency department. So they found that although there is no significant effect on the return visit or hospitalization, but the data suggests that may had improved the use of antimicrobial agents. So another study is pharmacist led antimicrobial stewardship program in an urgent care setting. So this study was aimed to evaluate the impact of pharmacist-led antimicrobial stewardship program in urgent care setting. It was a retrospective quasi-experimental study and every patient who had visited the urgent care unit with positive urine or wound culture was included. The primary outcome was comparing guideline adherence to antibiotic prescribing pre and post antibiotic stewardship implementation. And the result was a significant improvement to guidelines adherence of antimicrobial prescribing when pharmacists are leading the antibiotic stewardship program. So what are the 5 ways that have been suggested by the CDC and SIDB that hospital pharmacists can be antibiotic aware? First of all was the verifying penicillin allergy, which is very common in the US. And the second one is to avoid duplicative anaerobic coverage, reassess antibiotic therapy, avoid treatment of asymptomatic bacteriuria, and use the shortest effective antibiotic duration. So the first one is verifying penicillin allergy. The data have shown that 5% to 50% of reported allergy are penicillin allergy, which is a very huge number. On the other hand, 90% and to 95% of patients that are labeled as penicillin allergic can tolerate a rechallenge. So how to verify? Or why to verify? Because to decrease the resistance of using the second line treatment of patients that have penicillin allergy, and also using the second line was related to lengthening of hospital stay, and also its cost effective if verifying and using penicillin instead of the second line treatment. But how to verify? First of all, you need to communicate with the patient. Take a history of beta-lactam use, as the data suggested that 95% of patients who labeled as penicillin allergic that can tolerate penicillin, and you need to take a full history of using other beta-lactams antibiotic like cephalosporin and others. And data also suggests that sensitization decreased by time. And also do a skin testing frequently. And some data suggests that a patient who has a skin test positive or a penicillin allergy before 5 years, that is negative when testing again after 5 years. And take a history of what kind of reaction that the patient has when they reported as a penicillin allergic. The second one is to avoid duplicative anaerobic coverage. This is a very important. We can see it in a hospital, in a community pharmacy, in a dentist, and everywhere. We see that prescription that has a double anaerobic coverage, for example, beptazo and metronidazole, augmentin and metronidazole. So we need to interfere with this misusing of antibiotic and clarify the indication of every antibiotics. And if it was only to double cover the envelope, which is normally not recommended. So when a pharmacist encountering a prescription with a double envelope coverage, first of all, reach the prescriber, communicate with the prescriber, and identify the indication for each and discontinue if not necessarily or have another indications. The third one is reassess antibiotic therapy. There is many strategies that we can reassess antibiotic therapy. First, by implementing the automatic stop order of antibiotic after a certain time, and also review the use or the need of antibiotic after microbiology result have sent. And also you can reassess antibiotic use in transition of care, like medication reconciliation. When the patient was discharged from the ICU to the ward, or transferred from ward to ward, or even at discharge, you need to reassess the antibiotic use or the antibiotic need when a transition of care is happening. Also, look for opportunity to switch from IV to BO administration of antibiotic, and de-escalate or stop unnecessarily antibiotics. Antimicrobial prescribed at discharge. Now, most of patients are taking their antibiotic at home. Data suggests that 60% of antibiotics are inappropriate. Also, review discharge prescription by pharmacists will enhance antibiotics use. These are the most important and the most recent field of the good or the benefit of pharmacists to be aware and implement the intervention to improve antibiotic prescribing and use. So this is a study a pharmacist-led prospective antibiotic stewardship intervention improved compliance to community-acquired pneumonia guidelines in 39 public and private hospitals across South Africa. So it was a multi-center pharmacist-led prospective study that included adult patients hospitalized with community-acquired pneumonia. The strategy used was pharmacist audit and intervention feedback in compliance with the community-acquired pneumonia bundles. Also, they assess the rate of compliance, level of length of stay, mortality during pre and post implementation of antibiotic stewardship program. Pharmacists also assess the drug choice, drug dose, drug duration, and opportunity for IV to oral switch, as well as diagnostic measures of radiology, admission criteria, and microbiology culture. The result was pharmacists had improved guidelines compliance by 60%, and although there is no difference in mortality have been shown in this study. So another study that intervention to reduce broad spectrum antibiotics and treatment duration prescribed at the time of hospital discharge. A novel stewardship approach. So this was a single center quasi-experiment retrospective cohort study pre and post intervention. They examine oral step-down guidance and pharmacist audit of discharge prescription. Also, the primary outcome was duration and use of antibiotics, and they found that intervention by pharmacists was associated with lower duration of therapy, although not statistically significant. There was a 50% reduction in broad-spectrum antibiotic use, a 14% increase in appropriateness of antibiotic selection, and there was no significant difference in treatment failure or readmission. The most important thing in these 5 ways is, in my opinion, is avoiding treating asymptomatic bacteriuria. So asymptomatic bacteriuria has been defined as a specified quantitative amount of bacteria that is found in the urine without any typical symptoms of UTI. So the recent guideline from IDSA that recommend against screening or treatment of asymptomatic bacteriuria, except in pregnant women or patients undergoing urological intervention. And a study has suggested that 45 to 65% of asymptomatic bacterial patients are receiving antibiotics, whereas there is a clear recommendation against using it in this specific indication. So this is a study was published in 2016 by Kelly and colleagues, evaluation of an antimicrobial stewardship approach to minimize overuse of antibiotic in patients with asymptomatic bacteriuria. So this study was a retrospective observational short review study before and after educational initiative of antibiotic stewardship program. So the strategies that have been used in this study was in-service presentation on asymptomatic bacteria provided to a target physician groups and clinical pharmacists. Also, there was a notification posted on physician offices, distribution of booklet cards containing an algorithm on asymptomatic bacteriuria diagnosis and treatment. Also, there was an electronic memorandum to hospitalists for asymptomatic bacteriuria management recommendations. And also pharmacists have an important role in participating in daily rounds with physicians. And also there was a daily review of common antibiotics for treatment of UTI by antibiotic stewardship program members. So this study aimed to explore the asymptomatic bacteria management among patients who had positive urine culture and absence of symptoms. So they found that antibiotic administered in 62% of asymptomatic bacteriuria patient in the before phase, whereas after implementation of antimicrobial stewardship approach, the percentage of antibiotic use decreased to 26% in patients with asymptomatic bacteriuria. So the last way that pharmacists can be an antibiotic aware is use the shortest effective duration of therapy. Now, shorter is smarter. Why? Because it has the same benefit in most infection with low side effect and decrease resistance. And some cases that shorter duration may not be appropriate. For example, if you do not have a solid evidence of the shorter duration is equal to longer duration, or in cases with critical ill patient and complicated infection. So this was a study done by Dr. Brad Spielberg that comparing randomized controlled trials of common infection with short versus long duration of antibiotic use. And as you can see here, shorter duration are equal in community-acquired pneumonia, VAB, pyelonephritis, intra-abdominal infection, and variety of infection that is have been approved by a randomized control trial that is short duration of antibiotics is equal to a longer duration. For community-acquired pneumonia, as an example, there was a study mentioned in this study where a short course of 3 to 5 days was compared to a long duration of antibiotics that used 5 to 14 days for community-acquired pneumonia. And there was no difference in the effective of this antibiotics durations. This study has been published in 2018, was duration of exposure to anti-pseudomonal beta-lactam antibiotic in the critically ill and development of new resistance. So this study is a single center retrospective cohort study that explore the relationship between anti-pseudomonal beta-lactam antibiotic use and the development of a new resistant. Patients with severe sepsis or septic shock and received at least one dose of cifibime, meropenem, or beptazo was included in this study. And the primary outcome was a development of a new resistance after 3 days of starting these 3 broad spectrum antibiotics. And they have found that each day of exposure was associated with increased risk of developing a new resistance. So every day on antibiotics have a negative effect on patients, communities, and healthcare systems. So let's go to the pharmacist role in different settings. So this is a general statement that every pharmacist is an antimicrobial steward. How can you be an effective member in spreading the awareness of antibiotic or antimicrobial use? First, you need to evaluate every order of antimicrobial, and you need to evaluate and verify the indication. Is it accordance? Is the medication accordance to the indication? If you have your local antibiotic guideline, also verify the dose, which is a very important aspect in antimicrobial stewardship. You need to do a dose adjustment or therapeutic drug monitoring for common antibiotics to optimize the effective of this antimicrobial. And also evaluate the duration of therapy and use the shortest effective duration. Also communicate with the prescriber for verification if there is double coverage or there is an abuse of antimicrobial in specific patient, and see what's the rationale that this physician has to back up his prescription of this antimicrobial. And also you can educate healthcare provider on the right selection of antimicrobial for the right patient in the right dose and the right duration. Also, you can do a dose optimization and suggested a duration of therapy of the antimicrobial. And also a very good site for pharmacists to interfere and do an antibiotic stewardship intervention is in the transition of care. When patients are transferred from unit to unit, or even at transfer from physician to physician, you need to assess the need for intervention, and you can, after assessing, you can de-escalate some inappropriate medication or very important intervention that's switching from IV to BO, or even stop unnecessarily medication. Also, at discharge, you can also review the need for continuation of antibiotics and use the data that back up your recommendation when suggesting discontinuation or switching of antibiotics. Also, you can educate patient on when to stop antibiotics. Also apply antibiotic stewardship intervention that have mentioned in this lecture if needed at discharge as well. So a new settings that pharmacists can be an effective member of antibiotic stewardship and improving the use and prescribing of antibiotics is in the outpatient setting. So CDC have published a core elements in outpatient settings to establish antimicrobial stewardship. And this element is commitment. You need to demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety. And also action for policy and practice. You need to implement at least one policy or practice to improve antibiotic prescribing and assess whether it is working and modify as needed. Tracking and reporting, communicate with the prescriber, with the patient, with other healthcare provider on how to improve prescribing of antibiotic of that policy that you have implemented. And also educate and expertise, provide educational resources to clinicians and patients on antibiotic prescribing, and ensure access to needed expertise on optimizing antibiotic prescription. And 30% of antimicrobial that have been prescribed in the outpatient setting was inappropriate. So this is a study that have been published this year by Peterson and colleagues. The effect of multimodal stewardship approach on antibiotic prescribing for outpatient with acute respiratory tract infection. It was order set implementation and education. So this is a quasi-experimental research study for 2 years period. That take place in outpatient clinics and enrolled all patients visiting the clinic that had been diagnosed with acute respiratory tract infection that included otitis media, pharyngitis, sinusitis, pneumonia, bronchitis, and other non-specific respiratory tract infection. And the intervention was during the post-intervention period, internal medicine resident to stuffing the clinic. Before entering the clinic, they received a 30-minute education of a specific diagnosis and treatment of acute respiratory tract infection. especially upper respiratory tract infection, otitis media, sinusitis, pharyngitis, bronchitis, and pneumonia. So the order set were incorporated into the electronic medical record. The order sets consist of diagnosis test and treatment option recommendation, both for symptomatic relief and antibiotics when indicated. And this recommendation was according to their current clinical guidelines. And the primary outcomes was evaluated antibiotic prescribing frequency for acute respiratory tract infection, consisting of bronchitis, sinusitis, pharyngitis, and unspecified respiratory tract infection. A second outcome include the rate of antibiotic appropriateness for each diagnosis, and also additional outpatient or re-visiting the outpatients clinics after 30 days of discharge. And they found a very interesting result that antibiotic prescribing decreased by 8%, almost the same as the data that was in a hospital settings, or maybe more. And also 15% increase in appropriateness of antibiotic selection. And also there was a significant decrease in 30-day clinic revisits from 2.3% to only 0.2%. So these are the take-home points of this lecture. So in my opinion, and I encourage you to believe in this statement, that every healthcare provider should be antimicrobial aware. And also double coverage most likely not appropriate. Bacteriuria does not mean infection. Shorter is smarter, and communication is the solution in every situation. Thank you so much for listening.
Thank you very much for informative lecture. We're going to ask the audience to write down any question for you. شكرا، الله يعطيك الصحة والعافية. إذا كان في أي سؤال أو أي استفسار ممكن تسألوه على خانة الQ&A.